All right, so everybody, today we are going to discuss on the vitamin K dependent coagulation, right? And we do guard the two different mechanisms to cover up today. That is the procoagulation and also the anticoagulation. So that this part of the diagram, this will speaks about the procoagulation, and the other half of the diagram will speak about the anticoagulation process, right? And so you have to remember one of the major things that the procoagulation definitely represents all of those mechanisms or the ways out how does the body actually forms the clot. It means that the procoagulation, the factors which helps your body to maintain the clot formation process, and the anticoagulation side that is preventing the excessive clotting into our body. So let's just first begin out with a basic concept, and over here you have to remember it, or let's first discuss the procoagulation one. Okay, do remember one of the physiological concept that vitamin K is usually being needed out into the liver to activate certain clothing factors. Okay, we do have the vitamin K inside the liver, and inside the liver, what is the vitamin K is doing? Vitamin K is specifically converting the inactive form of the clothing factors that we have discussed in our last lectures, right? And we do guard certain factors like the 2, 7, 9, 10, and also we do guard some of the proteins like the C protein and the S protein. We'll talk about these proteins later on too. And so what is being actually needed of for all these inactivated clothing factors to make out them the functional factors, right? We do require vitamin K for that one, okay? And so if you do guard the vitamin K, definitely, right? Because all of these are the vitamin K dependent factors, right? So what is going to happen out? Like not only the vitamin K, but also one of the enzyme which is converting the inactive clothing factors into the mature clothing functional factors. We do require one of the enzymes that is the gamma glutamyl carboxylase, right, which is also vitamin K dependent. It means that if we do have the vitamin K, this enzyme is going to work out well, and the conversion of the inactive clothing factors is going to be ultimately gets converted into the mature and also the functional clothing factors. Okay, now we are going to make it out the whole of this situation quite simple, right? You have to remember it all one simple thing. We do guard the vitamin K's reduced form, right, into the liver, which is the active form of the vitamin K. And this reduced form, after being getting used, right, definitely going to be oxidized and becoming inactive, right? But after getting it used, this gets or recycled back to the active form by the help of one of the enzyme known as the epoxide reductase. Okay, and so you can just try to remember it off that these two enzymes are absolutely important for the key function of the vitamin K inside our liver, right? One of the major concept over here, you have to remember it out about the warfarin therapy, that whenever we do got warfarin therapy, right? So this warfarin actually prevents the vitamin K from getting being recycled back into its active form, right? And what does that mean? If the vitamin K cannot be reactivated, so of course the gamma carboxylation, right, this will be also reduced because we do not have the active form of the vitamin K, because this enzyme is also vitamin K dependent. So what is going to happen out? This happens out into result into the production of only and only fewer or the lower functional clothing factors, right? And that is why we do usually claim that warfarin always and always act as an anticoagulant. Okay, so the more specifically speaking, we have to remember it out that the warfarin inhibits vitamin K oxidized reductase, right? So let's say that if we do have one of the patient, right, and one of the patient does have the vitamin K deficiency, so there is the decreased synthesis of the functional factors, right? All of these one. So this simply means out that the vitamin K deficiency leads to the reduced synthesis of all these factors too. Okay. Now there could be some of the common causes of the reduced vitamin K deficiency that you can remember it out. Because if we do guard the vitamin K deficiency, we definitely guard the chances of the bleeding, right? And some of the basic causes, they do include the poor nutrition, right? The malabsorption, the liver diseases, any sort of the newborn state, and the suppression of the gut bacteria by the broad spectrum antibiotics. Okay, so you can just simply ask that why are neonates right? The newborn babies are at the risk of vitamin K bleeding, right? Why does the newborn babies are at the risk of the vitamin K deficiency bleeding, right? So the very first thing that you have to remember it out of all this answer, that the newborns, all of the newborns, right, they do have very low vitamin K storage, okay? And they also do not yet have the enough gut bacteria to produce the vitamin K. So that is why vitamin K is usually being given out earlier after the birth to prevent the neonatal bleeding, right? So you just see that we do also guard into the notes that the neonates they lack the enteric bacteria, means the gut bacteria which produce the vitamin K. So early administration of vitamin K overcomes the neonatal deficiency or coagulopathy, right? This is clinically very important to remember because the newborn babies they do receive the vitamin K extra, right, to prevent the bleeding, right? And so do remember that why can the broad spectrum antibodies, right? Another question to discuss that why does the broad spectrum antibodies they cause the they cause vitamin K deficiency. Okay, why does the broad spectrum antibodies cause the vitamin K deficiency? This is also another clinical scenario that you must have to remember out, right? And now you must have to understand what are the broad spectrum antibodies before we answer all of these ones, right? So you do remember it are the broad spectrum antibodies, right? We do got the wide range of all these ones, okay? And when you will learn the pharmacology, we'll get to understand that. But usually or briefly, you can just remember it out that the broad spectrum antibodies are usually some of the pharmacological agents, right? Which act against a wide variety of the species. Okay, for example, we do got some of the gram positive and we do got gram negative microorganisms, right? So they do actually act upon onto that, right? So you'll get to understand after learning the microbiology and the pharmacology. But do remember that we do got the broad spectrum antibodies. And why does the broad spectrum antibodies cause the vitamin K deficiency? The main reason is that because the some of the gut bacteria that produce your vitamin K, right? And the broad spectrum antibodies, they act the broad spectrum antibodies, antibiotics, they actually reduces, right, or they suppresses the gut flora, right, and so definitely leads to the deficiency of the vitamin K. Okay, and so after that, you have to remember it all. One of the important concept on the half life. Okay, the half life. What does that mean? There we do got different clothing factors, and do remember that the different clothing factors have the different half-lives. Means out that factor 7, okay, physiologically the factor 7 has the shortest half-life. The factor 7 does have the shortest half-life, and that could be around 6 hours. Okay, 6 hours. And the factor 2, it got the longest half-life, right? And the factor 2 name is also thrombin, as you have learned in the previous lecture. And this would be about 2 to 3 days. Okay, this is about 2 to 3 days. So you see the difference? The half-life for the factor 7, that is around 6 hours, but for the factor 2 thrombin, that is of about 2 or 3 days. So what happens when a patient is on warfarin therapy? Whenever a patient is on the warfarin therapy, warfarin is going to block the vitamin K recycling in the liver, right? So which means that the liver cannot produce properly functioning clothing factors, right? And specifically the factor 2, 7, 9, 10. So the clothing factors are already present in our blood, but they disappear instantly, right? They decline over the time based on their half-life. Now, my question to you guys is, which one is going to drop first amongst all of these ones? So the factor 7 is going to drop initially or at first. Why is that? Because of the having shortest half-life, right? And which is going to be living inside to that one for a longer time, that is going to be the factor 2 because it got the long half-life, right? So do remember about this factor 7, as we have discussed in our last lecture, that the factor 7 belongs to the extrinsic pathway, right? And so extrinsic pathway is going to affect it first now, right? Whenever someone is on the warfarin therapy. So now just think about the test again. What is the test which monitors the extrinsic pathway? That is the PD test, right? That monitors that one, and that measures the extrinsic pathway. So as soon as factor 7 levels are fall, right, the PT starts getting prolonged, of course, right, because that monitors the levels for that one, right? And so that is why the PT, or this is a prothrombin time, right? The lab test is the earliest lab abnormality in the vitamin K deficiency or during the warfarin therapy being given out, right? So we can just simply say that the warfarin, it prolongs the PD time. It prolongs the PD time first because the factor 7, it does have the shortest half-life, right? Now, if we just talk about the reversal situation, what if we give the vitamin K? What is going to happen out? So we are allowing actually the liver to produce new functional clothing factors again, because you see that the warfarin is inhibiting the vitamin K, and we are having the low clothing functional factors, right? So what if now we start giving vitamin K? So we begin actually, or we allow the liver to produce new functional clothing factors, right? And this process will take the time from usually several hours to a full day. Why is that? Because of the half-life, right? And so the vitamin K will work, but the vitamin K activity will be slower, right? It will be slower. So can we wait into such patients who really needed to get activated the clothing factors quickly? No, because the vitamin K activity will be slower. So let's say that we do have a patient on the warfarin, right, with a life-threatening bleeding. Can we wait for the vitamin K to act? The answer is no, right? We cannot wait that much longer. So that is why we do need an alternative or something else as an alternative that could act immediately, right? And this is why we specifically give out some of the direct clothing factors to that patient using the fresh frozen plasma, okay, which is also to be known as abbreviated as FFP, right? Or we also give them the PCC, right? PCC. This PCC means our prothrombin complex concentrate. Prothrombin complex concentrate, right? So that is why we do give out to them which are having the serious life-threatening bleeding factors, and they are also on the warfarin therapy, right? So not only the vitamin K therapy giving out will be enough, we must have to give them the FFP and also the PCC administration altogether to that one in cases of the severe bleeding, right? So both of them it gives out to be clear, right? So the answer should be, whenever it's been going to ask in the examination that a patient is on the warfarin with the serious bleeding, what do you do? The correct answer is, okay, we can give them the vitamin K because the vitamin K will active, right, all the functional clothing factors. This would be the first thing. And second thing, you have to remember it out there, you are also going to give out the fresh frozen plasma, and you are also going to give out the prothrombin complex concentrate alongside with that one. So this is the complete and the full concept related to the pro-coagulations, right? Our next topic of discussion will be revolving around the anticoagulation that would be discussed in the part 2 of this lecture.